Good morning. And we want to welcome you to the 2011 Parkinson's Disease Community Education Day. And we are so glad to have you here. I wondered how many have been to this Community Education Day in the past? Can I see a show of hands? Very good. And how about new folks this year? Very good. Well, thank you. We hope it will be as good as it has been in the past and that the new folks will really enjoy today. I'm Kathy Morton, and I am president of the Richmond Metro chapter of the American Parkinson's Disease Association. And we are so glad that you have joined all of us for this day. Want to do a couple housekeeping items first. If you haven't already found them, we have the bathrooms right outside this door. So if you need to get up, please there. If that is crowded, you can go back around where we had the Dr. Boyce this morning, and there's also bathrooms around there, so near the Chesapeake room. Want to thank all the exhibitors that are here. They are out to your right, to my left, but please visit with them today. They've come and have offered many services for us as people with Parkinson's. Also want to bring to your attention at the very back of the exhibition hall is a quilt. Has anybody seen the quilt? Yes? Well, we are very lucky to have in the room someone who made one of those squares. And Cheryl Majeski, will you stand up? She's all the way in the back. Cheryl is a quilter, and she submitted this to the Parkinson's Disease Foundation. There are 29 quilts that have been quilted. And if you will look down on the far left side of the quilt, she's the third quilt square down, so please look at it. And it's beautifully done. So, yes. Cheryl also, when the president of APDA retired, she was asked to make him a quilt, so that was quite an honor. It's beautiful handwork. Want to let you know that lunch is going to be in this room today, so we've got a little bit of break, but lunch is around 12. We'll try to keep it as much on time as we can, but lunch will be in here, and they'll bring it to you. Also want to bring to your attention there is a raffle. If you know Miriam Hirsch, which is over here, her daughter, Eve, is selling raffle tickets, so that is for fundraiser for Parkinson's disease. So we'll be doing that about at around 1 o'clock today during the lunch. We'll eat, have a few minutes to network with you folks at the table, and then we'll do the raffle after that. So please help yourself to raffle tickets. We got great items. Also, the Showalters, I want to thank them for the beautiful flowers at the registration. Did you notice those beautiful dahlias? Thank you so much. They already said they think the frost is going to get them, so they've called home and told the family to just start cutting. So when we leave here, we're all going to their house to get dahlias. But thank you so much. They're beautiful. Want to bring to your attention in everybody's packet, there is an evaluation form. It usually helps to evaluate after the speaker, so if you don't know the names, they don't all run together by the end of the day. So please, it is very important for the planning team for next year to know what you want and what speakers and what you like and what you don't like. So please, if you will fill that out as you go along. Also, there are 2 fundraisers that are going on right now for Parkinson's in the Richmond area. And one of them is tulips. You know, that is the flower of Parkinson's. So in your packet, there's a flyer. But if you go online, you can order pesticide-free tulips from right here in Virginia. So we hope you'll take advantage of that and raise money for Parkinson's. And also, Denise Barker is at the very back of the room. Will you wave your hand? She has done an exceptional job on getting a cookbook together, and it's called What's Shaking in the Kitchen. So please, it's wonderfully done. She had done this with another group and took on the project, so thank you. She'll also be in the back selling the cookbooks. They're $10 a piece. So please, if you haven't gotten one and you love to cook, please pick up one. Also, we want to thank all of the exhibitors, our supporters, and the pharmaceutical companies. We could not do it without them. So please go out to the hall during breaks and things like that and see them. And also this morning, how many went to Dr. Boyce's session? Very good. Well, we thank him for doing that and for all of you attending that group. Well, let's get started. We're ready for a long day, but an exciting day. Susan Dietrich's going to come up and introduce our first speaker.
I'm Susan Dietrich, coordinator of the American Parkinson Disease Association Information and Referral Center of Virginia, and I want to add my own welcome to you. This conference is also somewhat of a birthday celebration, as the APDA turned 50 this year. So please take time to glance at the APDA timeline at the literature table. It's multiple pages, but I have it out at the APDA information table. And you'll see the numerous contributions of this dedicated organization to the Parkinson's community. It's quite impressive. Dr. Fred Wooten, our first presenter, is a professor of neurology at the University of Virginia Health System, having also served as the chair of neurology. He's the medical director of the APDA Information and Referral Center of Virginia and served as chairman of the APDA Scientific Advisory Board since 1997. This year, Dr. Wooten was named the APDA Scientific and Medical Affairs Advisor. Please join me in welcoming Dr. Wooten.
Thank you very much, Susan. And certainly, I'd like to add my note of gratitude to Kathy and Miriam and Susan and Lynn for putting together this program, and let's give them all a hand. Lynn was very specific in my initial assignment today to give some updates, both from Staten Island and from Charlottesville. I don't think that there's any secret that the, can you hear me okay in the back? Yes. I don't think that there's any secret that the financial status that we're in the U.S. Has not had a significant impact on the APDA. We've had to drastically reduce the research support. We have been able to keep the information and referral centers open. And it's my goal in the next year, if at all cost, we can reinstitute the COTSIUS Award program, which I think is probably the highest impact research support program that we've had over the years. And that's, just to remind you, that's an award in memory of Dr. George COTSIUS, who really practically introduced levodopa to the field. And it's a 3-year award to a junior person who is transitioning from their training period into an independent career as a researcher. And just to give you an idea of the impact locally here, Dr. Bennett, who's going to be talking later today, who's now the chair of neurology at VCU, was the recipient of that award in 1983. I'm not going to argue that that's the only reason he was successful, because it isn't, but I'm sure it didn't hurt any. Also, Dr. Joel Trugman from UVA in 1987. He's now with Forest Laboratories. Dr. Madeline Harrison in 1991, who's now a professor of neurology at UVA. Dr. Russell Swerdlow in 1998, who is now a professor of neurology and a leading researcher out at Kansas University. And most recently, Brad Miller, who has worked with Dr. Bennett. So this is a very impactful award, and hopefully we will have the budget to reinstitute and have applications and support there. In terms of the center at UVA, I think certainly the highest profile project that's going on right now is the MRI-focused ultrasound program. This is basically a new technology in which treatments for various conditions in the brain can be applied via ultrasound waves externally. And it's the huge, there are several potential huge advantages to this new technology for making holes in the brain in the place of thalamotomies and pallidotomies, where you don't have to invade the patient's brain and make holes in the brain. It can be done non-invasively. And another treatment modality that it may have an application for is treating brain tumors as well. The neurosurgeon who's primarily involved with this program in Charlottesville is Dr. Jeff Elias, and he has now completed the initial 15 patients with essential tremor who've been treated with good outcomes, with no complications. One of the critical variables will be for us to follow these patients and see how long-lived the benefit is, because that will be important in determining how valuable this new addition for therapies will be. But in addition to being non-invasive, this technology allows reversible lesions. You can change the metabolism in an area of the brain, in a very small area of the brain, reversibly, and figure out if you're in the right place, for example, to reduce an essential tremor. And in Charlottesville on Monday and Tuesday of next week, we're having a Focused Ultrasound Foundation strategy session to plan a definitive study of focused ultrasound for the treatment of essential tremor. And we'll also be doing a planning session to develop a protocol to take to the FDA to treat patients with Parkinson's disease who have severe tremors that we can't control with medication. So I think this is an exciting technology. We'll see where it goes. We're trying to do the systematic development and ensure that it's safe and effective. But it certainly provides a new and potentially safer and effective approach to lesioning in the brain. And there are a number of other applications that are being studied in different parts of the world now for other brain problems, but our interest in Charlottesville is going to be primarily in tremor initially. Okay, so those are a couple of updates from Staten Island and Charlottesville. As I was driving down here this morning into the beautiful rising sun, I got a little reflective and thought about how I got started on this course that I come here each year and talk about Parkinson's disease with you, and we discuss it together. And it really, this trip for me started in the summer of 1966, after my first year in medical school. That was I was in New York City, just finished my first year of medical school at Cornell on the east side in Manhattan, and stayed in New York for the summer to do a research job. And it was a very eventful summer for me, that my whole life got set in this direction. The #1 song on the hit charts that summer of 1966 was called "Summer in the City." Dr. Bennett, who recorded that? Anybody remember? The Lovin' Spoonful. That's right. That's right. Lovin' Spoonful. And that was the anthem of New York City that summer. That summer, I met my first wife in New York, and that was very important. And on a more sober note, a very moving part of that summer for me, as life can throw you curveballs, my best friend and next door neighbor from Talladega, Alabama, where I grew up, Hugh Brown III, who was a graduate of West Point, class of 1965, was killed in Vietnam in July as he stepped off a helicopter in the Mekong Delta. And finally, to really put the icing on the cake for a very amazing summer for me, I was able to spend several days in Dr. Coetzee laboratory in Brookhaven out on Long Island, where he was administering kind of handmade little capsules of plain levodopa to patients with Parkinson's disease. And I was pretty much overwhelmed by seeing people sitting in wheelchairs unable to move and putting capsules in their mouths, and then within 45 minutes to an hour to be able to get up and walk. And I think the wonder of that it's very linear from there to here. The fascination with how dopamine works in the early part of my career, and then as my cognitive skills have eroded, I've tried to take on larger, to consider larger problems like what causes Parkinson's disease, and ultimately how can it be prevented or attenuated or cured. And so it's been a wonderful run from there to here. And what I'd like to do today is to discuss briefly, for your benefit, to understand kind of where the field is now in research in terms of causality of Parkinson's disease. And to introduce those, the 5 areas that are on your handout, if you want to follow them along with me, I think it's important to understand to review what our concept of Parkinson's disease is now, because I think that's been one of the major areas of progress that we can point to over the past 10 or 15 years is to understand that when I got into the field many almost 40 years ago, we thought that Parkinson's disease was pretty much exclusively a disease of dopamine dysfunction. Dopamine nerve cells die, causes bradykinesia, rigidity, and tremor. We give levodopa, the symptoms get better. But what's really emerged, I think, through very careful pathological studies, particularly by Dr. Brack and his colleagues in Germany, and by epidemiologic studies that have carefully looked at the premorbid state of patients with Parkinson's disease, we understand now that Parkinson's disease is a very long, slow process, and the early stages are to a significant degree fairly silent. We still diagnose Parkinson's disease in the clinic by recognizing some combination of slow movements, a paucity of spontaneous movements, tremor, and stiffness. That's all we can. Those are the tools that we have, and those are exactly the characteristics that James Parkinson described in 1817. That's how much progress we've made in diagnosing this condition. But what's now very clear is that there's a phase of variable length of time that precedes the development of stiffness and slowness and tremor and that we recognize as Parkinson's disease, that's tremendously varied. And it includes GI dysfunction, particularly constipation, difficulty swallowing perhaps, denervation of the heart, which is not very symptomatically important, but it can be demonstrated to occur perhaps prior to any of the classic symptoms of Parkinson's disease. We know that there are sleep disorders, particularly REM sleep behavior disorder, where patients act out their dreams and have dream enactment behavior, where it wakes up the bed partner, but it doesn't wake them up. And I'm sure many of you know what I'm talking about. and that characteristically can occur sometimes years before the typical manifestations of Parkinson's occur. And finally, anosmia, the loss of sense of smell. And these kind of seemingly unrelated symptoms that can occur prior to the onset of classical Parkinson's are associated with pathology, including Lewy bodies and nerve cell death that are now recognized as occurring before the substantia nigra, where the dopamine neurons are attacked by the disease process. And then the other side of the coin is that in the later stages of Parkinson's, it's very clear that another cluster of symptoms and problems develop that are not related to the deficiency of dopamine, and they don't respond to dopaminergic drugs. And these include problems with freezing and balance and falling, and problems with cognition, and problems with depression and apathy and fatigue that cluster in the later stages of Parkinson's and don't really benefit from dopaminergic therapies. So it's this understanding of this slow kind of ascending process of dysfunction in the nervous system and the progression from kind of peripheral problems to central problems that we now understand and represents the obstacle or the goal or the challenge to try to understand this disease. It's not just a disease of dopamine nerve cells. So let's look at these five. I certainly wouldn't argue that these are the only five notable lines of research. There are five that I chose because I think they're interesting and important. And first of all, the question is, why are dopamine neurons uniquely susceptible in Parkinson's disease? That is the characteristic core feature that we diagnose Parkinson's disease based on. And the damage to dopamine neurons forms the basis for the rational treatment of symptoms of Parkinson's with dopaminergic drugs like levodopa, ropinirole, and pramipexole. Okay? Now, this work that I referred to by Dr. Jim Surmeyer at Northwestern University is really fascinating and may turn out to be very important. Whatever it is that causes Parkinson's disease, clearly dopamine neurons are susceptible, and they're more susceptible than most of the other nerve cells in the brain. Why is that? And what Dr. Surmeyer has studied, he's a physiologist, and what he studied is the nature of the dopamine neurons are kind of like pacemaker cells. They don't fire real fast and then silent, and they're not real active when you're physically active and go to sleep when you go to sleep. They have a pacemaker quality, and they just kind of constantly pump out dopamine. And the physiologic basis for this clock, for this kind of rhythmic firing that they do, in newborn nerve cells in the brain, the depolarization, repolarization is carried out through the passage of sodium through the nerve cell channels, or sodium channels. But as nerve cells mature, this process is switched from sodium channels to leakiness of calcium channels, where calcium passes through the nerve cell membrane and is pumped out, and it causes this repetitive pacemaker type of function. And we know that when there's too much calcium in cells, it's bad. It causes all kinds of bad things to happen, much worse than sodium. And there's a huge body of evidence that having too much calcium in cells leads to all kinds of problems, including programmed cell death. And Dr. Surmeyer wondered if it would be possible to block calcium channels in experimental animals and see if somehow they could start using the sodium channels again. And he used a calcium channel blocking drug called isradipine. And lo and behold, in the test tube and in experimental animals, the dopamine nerve cells, just by treating with this calcium channel antagonist drug, which is in use today, kind of turn the dopamine nerve cells stopped using calcium to make their rhythm and were reverted back to the fetal form of sodium channel pumping, okay? And he called this rejuvenation. A catchy term. It certainly caught my eye. The ensuing line of research now has led to a clinical trial that will be, I'm not sure it's enrolling yet, sponsored by the Parkinson Study Group, to do a double-blind placebo-controlled trial of isradipine in patients with Parkinson's disease to test the hypothesis that converting dopamine nerve cells from calcium leaking to sodium leaking could protect them from whatever the process is that causes them to die in Parkinson's disease. And there are several other actually interesting lines of research as well, asking the question of why these dopamine nerve cells are so susceptible. This may not turn out to be the important observation, but it's certainly one of the interesting ones to keep our eyes on as a line of research. So keep your eye on why these dopamine nerve cells, what is the property of these cells that makes them particularly susceptible to the process that underlies Parkinson's disease. The second area is to report on a large genome-wide association study. Now, these genome-wide association studies are a relatively newer form of genetic study to try to find variations in the genetic code that occur more often in a disease population than in an age and sex-matched control population. In this case, a group of Parkinson patients and a group of age and sex-matched patients. And so using these kinds of studies with little tiny markers of segments of DNA, researchers have been able to identify a number of risk factors, if you will, of genetic risk factors that are small but significant influencers on risk for Parkinson's disease. And in this particular study by Zhang et al., they were studying sets of associated genes that were different in Parkinson patients as opposed to controls. And they found a really fascinating observation that a group of genes that are very related functionally, that involve the regulation of electron transport in mitochondria, where oxygen and glucose are converted to energy, genes that regulate glucose transport, glucose utilization, and glucose sensing, are in step underexpressed in patients with Parkinson's disease, in dopamine nerve cells and in other tissues. And the really important observation was that there is a receptor that controls all of these sets of genes together, and that they are underexpressed in Parkinson's disease. And so one possibility would be that if drugs that will stimulate these receptors can be identified and used, that this underlying defect in energy production, which seems to be a very common theme in thinking about the underlying causes of Parkinson's disease, could be a means of ultimately treating this condition. Now, I hope Dr. Bennett's going to talk about his research is right up the alley of this. I think it's very important, and I'm looking forward to his comments today because I hope he's going to be talking about this a bit. I'm following it with great interest. Okay? A third interesting area that I think is it almost comes in from left field, but it's an important advance potentially. Really began with the observation. You know, a number of years ago, there was a big National Institutes of Health study sponsored by the National Institutes of Health to transplant fetal dopamine nerve cells into patients with Parkinson's disease. And the bottom line on the study was that there was no net benefit to the patients, and some of the patients had these runaway dyskinesias after the transplants. But the kind of unexpected outcome was that in a couple of the patients who subsequently died and who postmortem studies were done on, they found that some of the transplanted nerve cells actually had Lewy bodies in them. And Lewy bodies are these little intercellular markers that are unique markers of Parkinson's disease. It's a diagnostic criteria that the pathologists use when they see those under the microscope. That's a characteristic pathological change in Parkinson's disease. And lo and behold, these fetal cells that were taken from fetuses had Lewy bodies in them in these patients. And it seems impossible that these donor cells could have developed Parkinson's disease on their own, so they must have come from the host patient who had Parkinson's disease. And this group has gone on to characterize in the test tube and in experimental animals that the the abnormal protein that's the most prominent abnormal protein in the brains of patients with Parkinson's disease, which is alpha-synuclein, when it loses its normal complex structure and sort of flattens out and becomes abnormal in structure and can't be digested efficiently, that this abnormal protein can actually be transferred from one nerve cell to another in the brain, almost like an infective agent, almost like a virus or a bacterium. And this is particularly of interest in Parkinson's disease because of Brack, the neuropathologist in Germany, whose studies have strongly suggested that the pathology in Parkinson's disease sort of is a wave that moves from the peripheral nervous system to the lower brain stem to the upper brain stem and to the higher centers in the brain. And potentially, one mechanism could be that the abnormal protein that develops can actually be propagated from one cell to another in adjacent areas. And so we have to pay careful attention to this possibility as an important mechanism, and also as a potential site for therapy in Parkinson's disease, if we can understand how this process occurs and then figure out how to block it from occurring. So the intercellular, the transfer from one cell to another of this abnormal protein that seems to constitute, it's a primary constituent of Lewy bodies and seems to be a real marker for damaged nerve cells in the brains of patients with Parkinson's disease. Okay, the fourth line of research that I would point to and comment on is the role of mitochondrial dysfunction in Parkinson's and whether it's primary or secondary. Now, and this is really closely related to item number 2. There is early evidence, it's now almost 20 years old, that the enzymatic synthetic capacity of mitochondria in patients with Parkinson's disease is diminished compared to controls. Secondly, there are two toxins, if you will, MPTP and rotenone. MPTP being a compound that some enterprising young chemists in California were trying to make synthetic Demerol, an opiate. And they took a shortcut in the synthesis of the compound and wound up making something they didn't intend to make, which was MPTP. And when a group of them injected themselves with this drug, they very quickly became Parkinsonian. And through some very nice detective work, Dr. Bill Langston and his colleagues showed that this contaminant got into the brain, got into dopamine nerve cells, and attacked complex 1 of the mitochondrial electron transport chain. And in other words, a very early key step in the conversion of glucose and oxygen to energy, and kill these nerve cells and made the patients dopamine deficient, and they looked like they had Parkinson's disease. Another toxin, which probably, certainly I've been exposed to heavily as I grow tomatoes, and rotenone is a pesticide that most of us use to treat our tomatoes with. Turns out that rotenone, when you administer to experimental animals in the right dosage and in the right schedule, will get into the brain and selectively kill dopamine nerve cells and other nerve cells in the body that are susceptible in Parkinson's disease. And it also acts by poisoning the complex 1 of the mitochondrial electron transport chain. So there are at least 2 examples of compounds that have the unique capacity. Their mechanism of action is to damage complex 1 of the mitochondria and reduce the capacity for mitochondria to make energy from glucose and oxygen, pointing again to mitochondria as a potential key site for the pathogenesis of Parkinson's disease. More recently, you know, one of the areas where we've learned the most, or I think we've learned the most about the process that kills cells in Parkinson's disease, is the genetics work that has been done in these rare dominant and recessive forms of Parkinson's disease. As you know, most people with Parkinson's disease don't have a family history. But there are a few that do, and through a different kind of genetic study called a linkage study, where you have a large family where multiple generations are affected, where you have affected patients and unaffected patients in the family, linkage studies can be done, and the gene responsible in these big families can be identified. And two of the 15 or so genes that have been identified that are linked to what looks like Parkinson's disease are genes that are intimately involved in mitochondrial function. One is called PINK1, which appears to be a structural protein in mitochondria. So very rare, it's autosomal recessive. And then another less rare autosomal recessive form of Parkinsonism that is called Parkin, and that gene, the mutations in that gene tend to affect the metabolism of mitochondria, the catabolism of mitochondria, and that again, here again is evidence pointing to a central role for mitochondria, either in causing Parkinson's disease or allowing the pathology in Parkinson's disease to evolve. So the role here of mitochondria remains, I think, an incredibly important focus, and it's certainly up in number 2, this genome-wide association study that showed the receptor that controlled the set of genes involved in energy metabolism certainly points to the central potential role of mitochondria. It may be that there's something else out in left field in the cell that comes in and hits the mitochondria and causes it to dysfunction, or there may be some inherent process in the mitochondria itself that renders it at risk for Parkinson's disease. But that turns out, more and more evidence points to trying to understand why mitochondria are dysfunctional in Parkinson's, what causes them to be dysfunctional, and what are the consequences of that? Is there anything that can be done about mitochondria that are structurally abnormal or and functionally abnormal? Okay. Now, and another, I think another important point for us to keep in mind about the importance of mitochondria. There are a number of kind of general theories of aging at the cellular level. What is aging all about? And one of the most common correlates, one of the most powerful correlates of aging is the accumulation of mutations in mitochondrial DNA that occurs with aging. And we know that by far the biggest risk factor for Parkinson's disease is age. That overwhelms all other risk factors, if you will. And all of us, as we get older, our mitochondrial DNA accumulates more and more mutations, and so the DNA that directs the development of proteins that are part of mitochondria become less and less effective, and the mitochondrial DNA abnormalities that occur with aging may be the substrate that's something else that we don't understand yet that's specific and can then interact with these dysfunctional aging mitochondria to produce the disease in some people but not in others. Okay? Now, as we go on to the fifth and final final area on my list of notable current lines of research. Another general theory of aging is that at the cell level is that cells age because they accumulate abnormal proteins that they can't digest and turn over. And all of our cells, as proteins age and they get a little twisted and gnarled and they don't work anymore, there are mechanisms for digesting them and turning them back into their constituent parts and then using them to make new protein, okay? And as cells age, these abnormal proteins tend to accumulate as the ability to digest them and reuse them kind of winds down. And there are two main systems in cells that carry out kind of the digestion and reuse of proteins within the cell. There's the ubiquitin proteasome system, and then there's the autophagy lysosome system. But these are essentially different mechanisms that allow for digesting and reusing protein. And there's increasing evidence now that the autophagy lysosome system is disordered in Parkinson's disease as opposed to age-matched controls, and we need to understand more about how that might be modified by medications or other treatments to make it more effective so that it will be better at clearing up these abnormal proteins that accumulate in the brains of patients with Parkinson's disease. So I think that these are just looking at the tip top of some of the areas where important research is going on now, that we need to keep our eye on. That certainly from the perspective of almost 40 years, it's incredibly exciting to see what we know about this process now compared to what we knew 40 years ago, much less 10 years ago. And so as we continue on this quest together for discovery and hope, I think we have lots of discoveries and lots of hope. And I thank you for your attention.
The next thing we have is exercise. Now, who loves exercise in this room? Raise your hand, please. Everybody's hand needs to go up. Well, Veronica Braum works at Simply Ballroom here in Richmond, and she leads a Parkinson's dance group. And I don't know if you've been reading a lot lately, but it is everywhere in the news about how wonderful dance is for Parkinson's. When Susan and I went to St. Louis last year, they talked about it, and we got up and we danced on a break. Well, Veronica has come today to lead us in an exercise and a dance group. So we have that for about 10 minutes. It'll get you kind of going for the morning. So please, she's going to set up. She's been teaching dance since 1992, and she came last year and was such a hit. That's why we've asked her back this year. So I'm going to turn it over to her. So you be ready for exercise and dance.
Check, check, check. Testing. Yeah, that might be good. Okay, is it on? Am I on?
Okay, hi everybody. My name is Veronica, as they mentioned, and I own Simply Ballroom Dance Studio in Midlothian. And I might need to move over a little because I'll need to use my arms a little bit, so maybe I can move this over a tiny bit. My dad had Parkinson's. He passed away about a year ago today, so that's what got me interested initially. It does seem to run in my family. A lot of my relatives have had it. And I did notice that my dad, while he had a lot of trouble moving and walking, he could dance and sing, oddly enough, and it didn't seem to be affected. So I wondered if there was something to that, and I got online and did a little research, and I found a group in Brooklyn that was Dance for PD. And I also got online and looked for Parkinson's support in Richmond and found Lynn Clanchar. And she and I went to Brooklyn and did the training. And came back and brought the program to Richmond. So it's been growing ever since, and it's a free class. We offer it every Wednesday. I'll leave some information, and if any of you don't live in the Richmond area, the website is danceforpd.org, and they can list all the places in the U.S. that have the program or show you how to start one in your own community if you'd like. So if you'd like to participate, what I'll ask you to do is kind of move your chairs around so you have a little room to spread your arms out so you don't knock over your neighbor. And I'll try to move my chair a little bit. See if I can actually put this in front, maybe. There we go. Okay, so just give yourself a little room so you can spread your arms a little bit without, like I said, hurting your neighbors. Okay, so we're going to start by sitting up nice and tall in your chair. This is as tall as I get, so I try very hard to do a little more. We're going to start with our hands in the center, and we're going to take them down, lift them up, and then bring them back to the center. I told you it's dangerous. And we're going to take them down again, lift them up, and then touch your shoulders. And then we're going to take our hands, flip them over, and we're going to push them up. And then this part is optional. If you feel comfortable, just reach down. If not, you can just touch your knees, and then you can come back to the center. Now we're going to take one arm and reach out to the side. It doesn't matter which arm. And then the other arm. And we're going to do that a couple of times, so 2 times in, 2 times out. Then the back stroke up and over. And the back stroke up and over. Beautiful. And then we're going to look down toward the floor. Look up toward the ceiling. Put one ear to one side and one ear to the other side. And then we'll start the whole thing all over again. So just do everything to whatever comfort level you have. If I'm doing something crazy that doesn't feel good, then just modify it. That's good. So I hope this music will work. Let's see if I can get it to play. Oops. I'm going to start it over just because it's not very loud. So let's see if I can get it to... Okay, sorry about that. Take 2. So we're going to take our hands down, down, up, and middle. Beautiful. Repeat, and down. Stretch it up, and shoulders. Flip the palms over, push it up high. Relax down. Back to the center. Beautiful. We're going to reach to one side and center. The other side, and let's repeat that one time. Out, in, excellent, out, and now we're going to do the back stroke. Up and over, up, beautiful, one more time, up and over, you got it, up, excellent. Now we're going to look down, down, center, and up. Now we're going to put your ear to one side and then to the other side. And now we're going to get ready and do it all again. Ready and go. So we have down, stretch, and center. Beautiful. Down, stretch, and shoulders. Push up, and now relax down. Back to the center, and we're going to go one way. Excellent, and now the other way. And repeat that. Side, beautiful. Side, excellent. Do a backstroke. Up and over. Very nice. Up and over. Perfect. One more time. Up and over. Excellent. And now we're going to look down to the ground and then up to the sky. And now we're going to go ear to one shoulder and ear to the other shoulder. And back to the center. And one more big down, up, and down. And give yourself a nice hand. Excellent. Very nice. You guys did excellent. I see a few of my regulars out in the audience, so I'm looking, they're looking good. We're going to do, I think we have time for a couple of dances, so I'd like to show you a little rumba rhythm. Rumba is a nice Latin dance originated in Cuba, and of course it has a lot of body action, maybe some hip action too. So we're going to take one shoulder and we're going to roll it back, and we're going to roll it back. Beautiful. And we're going to do the other side. Roll, and just do as whatever is comfortable for you. Very good. And we'll repeat that a couple of times. And then we're going to take our arms and stretch them out. And you're going to reach to one side and then to the other side. Beautiful. It's like you're reaching across a countertop and trying to reach what's on the other side. And try to keep both cheeks planted, so we don't want anything like that. And now we're going to take both arms and legs and stretch everything open. And then we're going to squeeze everything tight. And then we're going to spread everything open again. And then squeeze it tight. And then we have a great big piano that we're going to play all the way around. And then all the way around. And it's a good thing my arms are short so I don't knock this over. Okay, so let me see if I can get the right song. My biggest challenge is the technology here, so one day I'll get the hang of this. One, two, ready, and we have a roll. Roll, other side, roll, beautiful, and then roll, 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 beautiful, stretch it out, stretch, stretch, excellent, open it up, stretch it out, squeeze, stretch, squeeze, beautiful, we're going to play the piano around, and the other way, beautiful, back to the shoulder, roll, 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 excellent, roll, beautiful, and stretch it out, you got it, open wide, and squeeze, good, open it up, squeeze it in, piano, other way, good, one more time, shoulder, 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 open it up, and in, that's it, open wide, squeeze, and now we're going to play the piano around, good, one more time, we have, maybe not. Squeeze, open, squeeze, play the piano, and last time, roll, roll. All right, thank you guys. Do you want one more, or is that, am I out of time, or do we have time for? Yeah, we got one more. Okay, this last one is going to be a little foxtrot rhythm. So I'm going to have to move a little so I can show my feet. Take one foot or the other, it doesn't matter which one, and we're going to go open, close, open, close, 5, 6, 7, other foot, and a 1, a 2, a 3, a 4, and a 5, a 6, a 7, and 8. Then we're going to do our toes, so you touch your toe and then the heel, toe and the heel. If you want, you can add a snap. toe and a snap. There you go, toe and a snap. Beautiful. And the last thing is heel and jazz hands out. Jazz. There you go. Heel. You got it. And a heel. Beautiful. Heel. Excellent. And then we'll go back to the feet. And if you're getting funky, then you can add your arm with the leg. You can get as much crazy as you want to out there. Okay, let's see if I can find my music here. Possibly one of these days. I saw a great t-shirt that I'm going to order for myself. It says Master of Outdated Technology, and it has a cassette tape on the front. Okay, so let's see if we can get, if I can get the music going. I'm sure you guys can do fine. Ready? And we have 1, 2. Uh-oh. Well, that wasn't good. Okay, take 2. I told you the music's not my forte. Okay. 5, 6. Here we go. Open and a close. Open and a close. Good. 5, 6, 7. Other foot. And a 1, and a 2, and a 3, 4, 5, 6, 7. Now the toes. We have toe and a snap. Toe and a snap. Good. Toe and a snap. Toe. Now the heels. Heel. Heel. Good. Heel. Uh-oh. I think I'm getting too wild up here. 1, 2, 3, 4, 5, 6, 7. Other foot. And a 1, 2, 3, 4, 5, 6, 7. Now the toes. Toe and a snap. Toe and a snap. Good. Toe and a snap. Toe. Now the heels. Heel. Heel. Good. Heel. Beautiful. And one more time. 1 and a 2, 3, 4, 5, 6, 7. Other foot. And a 1, 2, 3, 4, 5, 6, 7. Now the toes. Toe and a snap. Toe and a snap. Good. Toe and a snap. Toe, and you got it. Heels. Heels. Heel. You got it. Heel. Good. One more time. Feet. 1, 2, 3, 4, 5, 6, 7. Other foot. 1, 2, 3, 4, 5, 6, 7. Now the toes. Toe. 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 You got it. And heel. Beautiful. And now both. Out. Uh-oh. You got it. And then up and over and about. Thank you, guys. Thank you guys very much for having me here. I'll leave some flyers for you, and I hope to see you soon.